Morphine and other strong opioids. Morphine is a strong opioid of first choice for moderate to severe pain in both malignant and non-malignant conditions. General rules for initiating opioid therapy in page 185. Starting an oral morphine. Start only with 4-hourly immediate release morphine. Give clear instructions. Initial doses. Adult, not pain controlled, with regular weak opioids, 5 to 10 milligrams of morphine every 4 hours. So initially you will start with codeine and uh, dihydrocodeine, but then if it is not, pain is not controlled with weak opioids like codeine and dihydrocodeine, then you will start with morphine. The initial dose of morphine is 5 to 10 milligrams every 4 hours. Elderly or cachexic patients or those not taking regular weak opioids, 5 milligrams every 4 hours. So you start with a lower dose. 2.5 milligrams if very elderly or frail. So the dose decreases because even this lesser dose will be effective in people who are not used to taking weak opioids or in the elderly. Titration of dose. Increase dose as needed by 25 to 50% per day until pain is controlled or the patient experiences unacceptable side effects up till a maximum of 120 milligrams per day. Risk of harm increases substantially at doses more than 120 milligrams per day with no increased benefit. Never attempt dose titration or for unstable pain using a fentanyl patch. Convert from oral morphine once stable dose is attained. Maintenance. Once pain is controlled, consider a long-acting preparation of equivalent dose, MSD by BD or MXD OD. Calculate the total daily dose of morphine by adding together the 4-hourly doses. Increasing dose. If further increase in dose is necessary, use a 25 to 50% dose increment to a maximum of 120 milligrams per day. Increase the dose than the frequency of administration. Slow release tablets are designed for OD or BD dosing. Breakthrough pain. Pain of rapid onset and moderate or in severe intensity despite background analgesia is called breakthrough pain. Management. Prescribe immediate release morphine for breakthrough pain. Give the equivalent of 4-hourly dose as an additional dose. If the pain starts to occur regularly before the next dose of analgesia is due, consider increasing the regular background dose. Common side effects of opioid drugs. Warn the patient. Nausea and vomiting. Affects more than 1 in 3 patients for the first 2 weeks of use. Prescribe a regular antiemetic for 2 weeks. Example, cyclizine, 50 milligrams TDS. If nausea and vomiting continues, consider an alternative opioid. Constipation. Consider prescribing prophylactic laxatives. Example, bisacodyl, 1 to 2 tablets nocti. Fentanyl causes less constipation than morphine. Drowsiness and cognitive impairment. Usually improves within the first week. Advise people not to drive, perform other skilled tasks, or work with dangerous machinery if affected. If not improving, consider an alternative opioid or refer for a specialist advice. Conversion to other preparations. There's a table. We will see the table for conversion of morphine. Reason to choose or switch to alternative strong opioid when there are unacceptable side effects to morphine. Renal failure. When there is renal failure, you cannot use morphine. Fentanyl is licensed for patients with renal failure. Oxycodone is safe in mild to moderate renal failure. So, fentanyl and oxycodone have to be used in renal failure. Unable to take oral medication regularly, consider fentanyl or buprenorphine patch or a syringe driver. Control drug prescriptions, page 125, syringe drivers, page 1030. So, this is a conversion. For quick conversion of oral morphine. Oral morphine, total dose, to subcutaneous diamorphine. Divide by 3. Oral morphine to subcutaneous morphine. Oral to subcutaneous morphine divide by 2. Oral to subcutaneous diaphragm divided by 3. And oral morphine to PO oxycodone divided by 2. If 24-hour dose is equivalent to 120 mg morphine or more, get a specialist advice. Opioid toxicity. Intentional or unintentional overdose produces drowsiness or coma. Opioid toxicity, as we had discussed, there will be pinpoint pupils, vomiting, hypotension. So in opioid withdrawal, there will be dilated pupils. Whereas in opioid toxicity, there will be pinpoint pupils. Confusion, including auditory or visual hallucinations. Respiratory depression because of toxicity. So how we will grade the opioid toxicity? If respiratory rate is more than 8 per minute, plus the patient is easily rousable and not cyanosed, adopt a policy of wait and see. Consider decreasing or omitting the next regular dose of opioid. See, you cannot stop the opioid immediately once they are in respiratory depression, because the opioids are not given just for pain relief. They are given for end of life pain reliefs, right? So you cannot stop the opioid dose immediately. So this is like a necessary evil for these patients. So as in case of warfarin and increased INR, so what you will do, you will omit 1 or 2 doses and then get back to warfarin. You have to continue the medicine, but you need to know what to do once you have unacceptable side effects. So if respiratory rate is more than 8, plus the patient is easily rousable and not cyanosed, so adapt up also wait and see. Consider decreasing or omitting the next regular dose of opioid. Stop the syringe drivers temporarily to allow plasma levels to decrease, then restart at a lower dose. If respiratory rate is less than 8, or the patient is barely rousable or unconscious or cyanosed, dilute naloxone 40 micrograms in 10 ml. So you dilute for 400 micrograms of naloxone in a 10 ml of sodium chloride 0.9%, and then that diluted solution you will be administering 0.5 to 1 ml IV every minute, because naloxone is very short acting, until the respiratory status is satisfactory, that is more than 8, and then you will wait and watch. If respiratory function still does not improve, question diagnosis. So question whether it is mainly due to opioid overdose or not. Further doses may be needed later, as naloxone is shorter acting than morphine. Muscle rigidity or myoclonus. Consider renal failure. Renal can produce myoclonus alone. Treat with rehydration. Consider stopping other medication which may exacerbate the myoclonus, switching the opioid, or treating with clonazepam. So at the end of the day, if you are not able to find out what is the cause, you can treat the myoclonus with clonazepam 2 to 4 milligrams per 24 hours depending on the circumstances. That means how much disability it is causing. Subacute overdose. Slowly progressive somnolence and respiratory depression. So common in patient with renal failure. Withhold morphine for 1 or 2 doses and then reintroduce at 25% lower dose. So when there is subacute overdose, most commonly renal failure patients. Opioid toxicity may be increased by renal failure, other changes in disease status like hepatic function, weight loss, dehydration, other analgesics like NSAIDs, co-administration of amitriptyline. So when you are administering amitriptyline, then there can be a risk of opioid toxicity. Management of drug misuse, page 166, we have already read about it. Neuropathic pain. Neuropathic pain occurs as a result of damage to neural tissue. Examples include post-herpetic neuralgia, complex regional pain syndrome, reflex sympathetic dystrophy, peripheral neuropathy, example due to diabetes, compression neuropathy, and phantom limb pain. Pain typically occurs in association with altered sensation like burning, stabbing, numbness. Pain may also be provoked by non-noxious stimuli, allodynia, example gentle heat or cold. Diabetic neuropathy, page 330. Postherpetic neuralgia, persistent neuropathic pain in the dermatome affected by the shingles. We'll be discussing in detail by page 628. Treatment of neuropathic pain. Trigeminal neuralgia. The drug of choice for treatment of trigeminal neuralgia pain is carbamazepine, unlicensed indication, often poorly tolerated. Oxcarbamazepine is an alternative. If no response in less than 8 weeks, refer early for specialist assessment and advice on pain control. So other neuropathic pain, where possible, treat the underlying cause of the pain. If that is not possible, consider treatment with amitriptyline, gabapentin, duloxetine, pregabalin. For all these drugs, start at a low dose and titrate the dose up according to the response. Consider capsaicin cream if localized pain and the patient wishes to avoid or cannot tolerate oral medication. Consider tramadol if only acute rescue therapy is needed. Review. So after you prescribe these patients with these medicines for pain, review after starting or changing a medication. Perform an early review 1 to 2 weeks to check the dose titration, tolerability and adverse effects. Once established on a particular dose of medication, review regularly 4 to 8 weeks to assess and monitor effectiveness of the treatment. Ask about overall perception of improvement, adverse effects, decrease in pain. Pain diaries may help. Sleep, ability to do everyday activities, example work, driving, mood, depression or anxiety screening questionnaires may be helpful. If improvement is sustained over more than 6 months, consider a gradual dose reduction over time. Refer to a specialist pain clinic or other appropriate specialist service if severe pain or pain significantly limits the activities, underlying health condition has deteriorated, inadequate response for first line drug like in trigeminal neuralgia or second or third line medication, all other neuropathic pain, then you need to refer. These are the conditions where you refer the patient. Antidepressants, amitriptyline, proven treatment for neuropathic pain, unlicensed indication. Start at a dose of 25 milligrams at 5 to 7 pm, 10 milligrams if elderly. Increase the dose by 20 to 25 milligrams every 5 to 7 days to a maximum of 75 milligrams in a single dose as needed. Higher doses under specialist supervision only. Some patients do not derive benefit for 4 to 6 weeks. Alternatives to amitriptyline include nortriptyline and imipramine. Both are given at an initial dose of 10 to 25 milligrams in the evening. Dose can be titrated up to 75 milligrams as needed. May have fewer side effects than amitriptyline. So next drug is duloxetine. Effective treatment for neuropathic pain, currently only licensed for the treatment of diabetic neuropathy, usually less sedating than amitriptyline. Start with 60 milligrams once daily, increasing to 60 milligrams BD after 2 to 3 weeks if inadequate response. Anticonvulsants, carbamazepine. Only recommended treatment for trigeminal neuralgia. Start with 100 to 200 milligrams 1 to 2 times per day, less if elderly or frail. Build up the dose slowly to the usual dose of 0.8 to 1.2 grams daily in divided doses, often poorly tolerated. Pregabalin is licensed for the treatment of neuropathic pain, initially 150 milligrams per day in 2 divided doses. If increase if necessary after 3 to 7 days to 150 milligrams BD, and again if needed to another 7 days after 7 days to 300 milligrams BD. Gabapentin, effective for neuropathic pain but less clinically and cost effective than pregabalin. Start with 300 milligrams 3 times a day. Increase in steps of 300 milligrams every 2 to 3 days as needed to a maximum of 3.6 grams per day. Slower titration is advisable for the elderly or frail. So both gabapentin and pregabalin are drugs of abuse. So monitor the frequency of repeat prescriptions. Be careful when issuing to temporary patients. NSAIDs, sometimes effective for neuropathic pain, either because there is mixed nociceptive pain or because decreased inflammatory sensitization of the nerves. There is a considerable variation in individual patient tolerance and response. Opioids. Neuropathic pain often responds only partially to opioid analgesics. Of the opioids, oxycodone, tramadol, methadone are probably most effective. Do not start regular treatment with opioids for neuropathic pain in primary care. Capsaicin, active ingredient in chili peppers, licensed for the treatment of neuropathic pain, applied locally as a cream 3 to 4 times per day. Advise patients to apply the cream sparingly in a well-ventilated room and wash their hands after use. Side effects include intense burning at the site of application and more rarely eye symptoms or sneezing. The cream should not be applied after a hot shower bath as it intensifies the burning sensation. Topical lidocaine. The plasters impregnated with lidocaine 5%, Versatis, licensed for post-herpetic neuralgia. Apply daily for up to 12 hours, followed by a 12-hour plaster-free period. Discontinue if no response after 4 weeks. Up to 3 plasters may be used to cover large areas. The plasters may be cut. Normal aging. This is page number 190, normal aging. So we need to know what is normal and what is abnormal in the geriatric patient. So of the UK's 6.5 65.6 million people, 18% are aged more than 65 years and 2.4% more than 80 years. Life expectancy is increased. Over the past 30 years, the population aged more than 65 has grown by 23%, with largest percentage growth among those more than 85 years. What is aging? Aging is a gradual series of changes over time that lead to loss of function of organs and cells, with eventual outcome of death. Normal changes of aging is noted in table 8.3. We will see individuals vary greatly in the rate at which they age. Several factors seems to influence this: genetic makeup, the psychological health, the lifestyle, diet, physical exercise, smoking, socioeconomic factors, and environment. Difficulties in assessing the elderly. Communication problems. So, when you are assessing the elderly, there will be communication problems because the elderly will not be able to communicate what is the problem. Hearing, cognition, speech, multiplicity of cause. One symptom may be caused by different concurrent problems like breathlessness as a result of COPD and heart failure. Non-specific symptoms or signs. Confusion, falls, off legs may be the only overt sign of underlying disease. Example, UTI, MI, stroke. Symptoms may be absent despite the disease and signs are harder to elicit. Polypharmacy may result in side effect and interactions. Laboratory tests may be unreliable, especially white cell counts and ESRs are unreliable, so always check the CRP. Disease. The aging process is compounded by overt disease. This may affect functional capacity, quality of life, and independence and cause frailty, decrease the well-being and independence, and result in increased care and mobility needs. Multiple morbidity. Older people are more likely to have several ongoing chronic illness that can act in combination to cause disability greater than either illness alone and result in direction of care at some problems with relative neglect of others. Polypharmacy, involvement of multiple specialist teams which can cause inconvenience to the patient and family and result in conflicting advice and opposing opinions on cause and effect of symptoms. Frailty. Elderly people are described as frail as a term used to describe individuals who are physically weak and fragile. Frailty can occur on a background of natural aging or be precipitated by disease. It is not a disease or disability, but an inability to withstand physical and psychological stressors. Common features include feeling of exhaustion, slow walking speed, unintentional weight loss, more than 5 kgs in a year, weakness, measured by grip strength, low levels of physical activity. Detecting frailty can enable support to be put in a place earlier to enable frail people to remain well at home and avoid crisis situations. No, normal changes of aging. So this is normal changes of aging, system and clinical functional effects. Cardiovascular. Cardiac enlargement or left ventricular hypertrophy, decrease in cardiac output, decrease in exercise capacity, decreased response of heart rate to exercise, systolic hypertension, left ventricular failure. Respiratory, decrease FEV1 or FVC, increase residual volume, increase susceptibility to infection, increase susceptibility to aspiration. Endocrine, decrease insulin sensitivity, impaired glucose regulation, decrease thyroid hormone production. Gastrointestinal, increase in gastric acid production, constipation. Genitourinary, decreased glomerular filtration rate not reflected by increased creatinine. Benign enlargement of the prostate, 25 to 50% of the men more than 65 years have prostatism. Slowing of sexual function, erectile dysfunction, dry vagina and increased susceptibility to urinary infections in females. Musculoskeletal, sarcopenia, decreased muscle strength, power, decreased lean body mass, increase in fatty body mass, decrease in mobility, increased likelihood of falls, osteoporosis, susceptibility to fractures. Nervous, slower thought process or reaction time, general decline in performance, Dementia is not a normal change of aging. Vision, presbyopia, difficulty in focusing on near objects. Decreased visual acuity, cataract. Impaired dark adaptation. Hearing, high frequency hearing loss, presbyacusis. Deafness affects 80% of the 80-year-olds. Degenerative changes in the inner ear leading to impairment of balancing caused by falls. Immune, atrophy of the thymus, reduced immune function resulting in increased infectious diseases, reactivation of latent TB, shingles, increase in cancer and autoimmune disease. Skin and hair, dry skin, wrinkles, tendency to bruise easily and slower healing, graying of the hair. Decreased sweating, heat generation and heat conservation. Heat stroke, hypothermia, decrease in sensitivity to touch, pain, temperature discrimination leading to burns and pressure sores. Falls in the elderly. Falls are a major cause of disability and a leading cause of mortality due to injury in people aged 75 years. Tendency to fall increases with age. The assessment of a patient who has fallen in common primary care is a common primary care emergency. So risk factor for falls. Recurrence increases with the number of risk factors. So first is females more than males 2 in 1 in over the 75s, increased age, multiple previous falls, disorders of gait or balance, visual impairment, cognitive impairment, low moral or depression, high level of dependence, decrease in mobility, foot problems, lower limb weakness or arthritis, history of stroke or Parkinson's disease, use of psychotropic drugs, sedatives, diuretics or beta blockers, alcohol, environmental factors, example loose rugs, poor lighting, ice, high winds, infection, example pneumonia and UTI. Assessment. Deal with the injuries first. Ask about the pain, loss of function, headache. Ask the carers about behavior. Checking for bruising, decreased function, confusion, BP, pulse, neurology, and funding. Consider hypothermia if on the floor for any duration. Investigate the cause of fall. Consider physical problems, neurological problems, example stroke, visual loss, cardiac abnormalities, arrhythmia, postural hypotension, muscular abnormalities, steroid-induced myopathy, skeletal problems, osteoarthritis, infection, pneumonia and UTI. Environmental problems. Climbing ladders to do routine maintenance, example loose or hold carpets, slippery floor, bath, chair on or bed too low. Management. Treat any acute injury 20%. Exclude a fracture, mainly the Colles fracture or neck of femur fracture. A subdural hematoma may take days or weeks to relieve itself. Even if uninjured, older people might not be able to get off the floor without help. The result may be a prolonged period of lying on the floor until the help arrives. Apart from the indignity or helplessness this causes, secondary problems like pneumonia, pressure sores, hypothermia, UTI, and dehydration may follow. Perform or refer to a specialist falls service for falls assessment. Undertake measures to decrease the risk of falls or damage from falling. Refer to an accident and emergency. If significant head injury or any suspicion of fracture, any other significant injury, example lacerations. Admit to acute medical care or an elderly care team if the cause of stroke, fall versus acute medical problem like stroke. Refer to the intermediate care rapid response team if the patient is unable to cope at home or the patient carer is worried about the possibility of further falls. Refer to the specialist elderly care team or falls clinic if the cause of recurrent falls remains unclear. Osteoporosis and prevention of fractures, page 482, we will see there. Prevention of falls. Falls are one of the biggest risk factors for fracture. All elderly people should have risk of falls assessed regularly. Any fall may seriously undermine an elderly person's confidence and cause worry about the possibility of recurrence. As a result, this may be restriction of activities, decrease in fitness, dependency on adults. So, is a fall assessment needed? Ask if the patients fall. They may not volunteer to the information spontaneously. The timed get up and go test may use as a walking aid. May use usual walking aid. Start with the patient sitting in a straight back chair of comfortable height with arms. Ask the patient to rise from the chair. walk in a line 10 feet or 3 meters away, turn around, return to the chair and sit down again. The timing while the patient is sitting, end time when the patient has sat down. At the time of 13 seconds, a time of more than 13 seconds predicts increased risk of falls. Fall assessment. If available, refer to a specialist fall service. Record the frequency and history of circumstances around any previous falls. Drug therapy like polypharmacy, hypnotics, sedatives, diuretics, antihypertensives may all cause falls. Assessment of gait and balance including abnormalities due to foot problems or arthritis and motor disorders, example stroke or Parkinson's disease. Examination of basic neurological function including vision, mental status, impaired cognition and depression, muscle strength, lower extremity peripheral nerves, proprioception and reflexes. Assessment of basic cardiovascular status including BP, exclude the postural hypotension, heart rate and rhythm. Assessment of environmental risk factors, example poor lighting, particularly on the stairs, loose carpet or rugs, badly fitting clothes or footwear, lack of safety equipment such as grab rails, steep stairs, slippery floors or inaccessible lights or windows. Measures to decrease the risk of falls and damage from falling. Correct the vision if possible. Correct postural hypotension. Alter the medication. Consider compression stockings. But many people, elderly people, cannot apply stockings tight enough to be used of any use to themselves. Treat other medical conditions. Refer to cardiology if there is asthma. Review the medication and discontinue if alter inappropriate medication. Remove environmental hazards. Arrange a bath at a day center. Refer to OT to identify or correct hazards in the home. Example, loose carpets, remove loose carpets, wheel trolleys for indoor use, commode or urine bottle at night, etc. Liaise with other members of the PHCT and social services to provide additional support if needed. Refer to a local council for care phone or alarm system to call for help if any further falls. Refer to rehabilitation of physiotherapy to improve the confidence after falls and for weight bearing exercise. Focus on strength and flexibility and balance training. Decrease the risk of falls. Use hip protectors to decrease the risk of fracture in patients at high risk, but compliance is a problem. So, prescribing for the older people. Use of medicines increases as people get older. 1 in 3 NHS prescriptions are for patients with more than 65 years of age and 90% of these prescriptions are for repeat medications. Adverse drug events are common reasons for hospital admission in the more than 75 years age group. Many are unavoidable. Regular review is essential. Problems commonly encountered. Polypharmacy. Elderly people often have multiple problems. It is easy to keep adding drugs for each and every new problem, resulting in polypharmacy. This increases the confusion about drug regimens and results in poor concordance and multiple interactions or side effects. Before prescribing a new drug, consider whether it is necessary, avoid treating normal changes of aging, use non-pharmacological therapies wherever possible, avoid a pill for every ill, approach and try to treat the underlying condition and not the problems. Balance the potential risk of drug against the benefits. The drug trials of efficiency of medicine often exclude older participants. The applicability of evidence to elderly patients cannot be assumed. For prophylactic medication like warfarin and statins, consider the likelihood of concordance and benefits in the context of the whole person, including other comorbidities. Review medications regularly. Stop ineffective or redundant drugs and consider if the overall drug regimen can be simplified. Form of medicines. Swallowing tablets can be difficult for the elderly people. Consider using liquid preparations, giving explicit advice to take medication with plenty of water sitting upright. Confusion after discharge. Up to half of all the patients are inadvertently prescribed the wrong medications after hospital discharge. Drug hoarding or self-medication. Especially if recent changes in medication it is common for the elderly people to have a backstock of drugs and continue taking the old drugs alongside the new ones. A written list may be helpful. Many elderly people also self-medicate extensively with OTC preparations. If unnecessary, do a home visit to sort out the drugs. Increase susceptibility to side effects. Common due to altered pharmacodynamics, increased susceptibility to GI side effects, example constipation with opioids, gastric irritation with NSAIDs, increased sensitivity to effects of CNS drugs like benzodiazepines, opioids, use with care. Pharmacokinetics. Decreased renal function is particularly important. Always assume elderly person has moderate renal impairment. Social and personal factors. Low level of home support, physical factors like poor vision, poor hearing, poor manual dexterity, and mental state, example confusion, disorientation, depression, can all affect the ability of an older person to take medications. Specific medicine. The B list is a list of agents to be avoided or used with extreme caution in the elderly patients. It can be accessed via the website. So we are done with today's dose of Oxford Handbook of General Practice. Thank you.